Our keynote address will be done by Dr. Mark Nanyingi, and the topic that he'll be presenting on is leveraging One Health approach to strengthen pandemic preparedness in Kenya. We welcome you, Dr. Mark Nanyingi, to make your keynote address. So let's appreciate him as he comes.
So my name is Mark, as Adija has introduced me, and thanks very much, Adija, and your team for putting up this. I think it's an honor for me to stand before you this morning just to share some of the ideas, the work that we've done, and also some of the planned efforts as a country of Kenya in collaboration with, of course, other institutions across the globe. But I think the emphasis is that we have been seeing a lot of pandemics, but the most memorable pandemic that have lived within our time has been the COVID-19, which decimated the entire world approximately 5 years ago. So my talk is going actually to highlight a few issues for some of you who are new to One Health, is that it is not a new concept. I think it has been necessitated by recurrent emergence of diseases over time. And what we have come to learn is that initially it was more domiciled in the animal health sector, but over the years there has been momentum to open up as an integrated and a unifying approach that actually brings together all these three sectors: the human, animal, and the environmental health sectors. So when you look at some of the graphics that have been put up here, basically that there's an intricate way of the three systems being inseparable. And the issue of AMR, because a lot of people think that antimicrobial resistance is a different issue, but it's also tied very closely to issues to do with One Health. So there are a lot of issues that come into this cocktail. You have issues to do with food safety and poisoning, but also at the interface of this is the role that wildlife plays, because wildlife plays a very significant role when it comes to the communities that interact, and there is a potential of spillover of infections. But as we look at this, we usually actually forget that even ourselves, we contribute to emergence of some of these diseases. For example, the cars that we drive every morning, the flying across continents, what we call the carbon footprint, and I think more importantly, even the food that we consume. And what is the role of climate change? I think climate change has been a stimulus, or probably a catalyst for all these things that we are seeing. Water bodies, and at the same time also just generally changes in biodiversity. When you go near a forest, for example, maybe it's Karura forest, or a forest that has not been, encroached, and you start cutting down the trees, then there's a potential that you're going to disrupt the ecosystem, and you will have actually some of these diseases jumping. So in a nutshell, it is a whole approach. One Health is not very specific to a discipline, it's a disciplinary issue, and globally we have what we call the quadrupetite. So the quadrupetite is the UN agencies that have come together with the World Animal Health Organization. So we have FAO, we have UNEP, we have the WHO, and then we have UA. So they drive the global agenda, but at country level, countries actually try to take this on their own. So we'll try just to demonstrate how these diseases have caused so much damage over some time. It's documented that almost 500 new outbreaks are reported annually, and most of these outbreaks have been at least affecting humans, but they jump from animals, and this is what we call zoonosis spillover. As we continue, the role of wildlife cannot be overemphasized, as I have already mentioned, that the wildlife actually are at the amplification point of most of these diseases. And the maps you see, you can see that there has been a steady geographical and epidemiological shift of disease over time. while diseases that afflict the African continent or areas that have what we'll call in quotes poverty, now it has become a global phenomenon, just beyond being neglected tropical diseases or probably neglected zoonosis. So it's like a bushfire that is spreading all over the world, and we've seen intensified transmissions of hotspots within the East African eco niche, but also we've seen recurrent outbreaks of Ebola over more in the Congo and other regions. But now here in our situation, for example, Kenya, we'll try to highlight a few issues that we've seen with Rift Valley fever, anthrax, and now we have mpox, which is a zoonotic disease. So the reason why I'm projecting this map, which is very busy, which was developed by our colleagues from the UKHSA, and they were gracious to share this map, is that over many years, we have actually seen this, what we call the epidemiological shift geographically. But interestingly, many of these diseases, they are re-emerging. So there's a difference between an emerging and a re-emerging disease. An emerging disease is totally new. It has never been probably genomically isolated, but also we have a re-emerging, and most of them are actually re-emerging diseases. But also we have a deliberately emerging. Deliberately emerging will be due to intentional introduction into areas, due to research, or probably due to aspects to do with bioterrorism. But the most constant thing is that more than 80% of these diseases, they jump from animals, they are zoonosis. And that is the focus of actually the more work that we've been doing for a very long time. In our country of Kenya, we have an array of diseases that are actually what I'll call a broad spectrum of zoonosis that have been epidemic prone over the years. For example, if you're talking about Rift Valley fever, anthrax, and now we have mpox, some of these diseases are actually intensifying their transmission to be, their endemicity increasing for them actually to become endemic diseases. By endemic diseases is that we know hotspots that have been occurring, but when you see the part that the pastoral and the agroecological zones actually dominate some of these areas geographically, you will see that areas to do with maybe Garissa, areas to do with Kajiado and others, they have that cocktail of diseases. And there is a possibility actually to have a concurrent infections. You can have Rift Valley fever occurring in one area and you have anthrax occurring at the same time. But the key drivers remain constant. Back to my first very nice infographic that was showing that rainfall, flooding, human population, issues to do with the exposure to animals, and even rodents to do with diseases like leptospirosis. Leptospirosis, I'm just picking it up because it's a very unique disease. Similarly, a disease like brucellosis, it's very difficult to diagnose brucellosis. And in most cases, you find that even the regimen for treating brucellosis leads to AMR because rifampicin at high doses is being used. So when you see all those, including hydroxidosis, you realize that Kenya has done a lot of work on the last part of this table, whereby apart from just strengthening the livestock and the human surveillance systems, I think there has been also efforts actually to drive vaccine availability and uptake for both animals and humans. But more importantly, actually, the aspects of the cross-border issues where communities that live across borders, for example, I'm very passionate about Kajiado, the Tanzanian side. Of course, we know right now what is happening, but routinely there's a lot of collaboration between counties that are contiguous on either side of the border. But we can't really ignore the role of food safety, because many people just think of zoonosis as being a disease that will jump from an animal. But our habits to either come in contact, to have exposure, but more importantly, even our consumption behaviors. An example is a place where I worked for some time in Western Kenya. So an animal has an anthrax, it's buried, and then at night they go and exhume, and then 3 people from that family die. So these are realities. This is not just academic issues, but these are issues that actually afflict us as a country. And now, how do we govern One Health issues? We've been trying actually to improve on this diagram for a long time, and it's not static. I think a lot has changed, but at the center of this, and I'm very happy that the Ministry of Environment has now come on board at the country level, but initially it used to be between the DVS. By DVS specifically is under livestock, and not the agriculture part as such. And at that time, in 2012, when this was signed into a working document as an MOU was with the Minister of Public Health and Sanitation, but now it's the Minister of Health. So what we've seen over some time, and it's continuing actually to build momentum, is that Kenya is one of the few African countries that has developed a robust One Health architecture, where the ZDU is at the center of this, and it has institutionalized this by actually bringing together all these sectors. But more importantly, you find that the head of the ZDU, the core heads of the ZDU will be from the animal health, and one will be from the medical, a medical epidemiologist. There have been a lot of success stories. I think Matthew Mutiria here, Adija, Dr. Okunga right now, they are the center of actually running this robust platform. And I think the challenge has been fully integrating this to the lowest level, at the subnational level, where we have what we call the Count One Health units. And the Count One Health units have been a success story because they are the deliverable points. We have technical working groups, and these will be academics, there will be research, there will be partners who come together on need basis. And to maintain these working groups, they will be disease specific, but also we have a bigger One Health technical working group that has been revamped. So the emphasis here is that we also want to understand what happens at the lowest level, from the national level where we have these architectural interactions between the three sectors. And this drives me to an initiative that we began 10 years back. At that time, I think I was working for the CDC, and the County One Health units was an initiative to pilot in 5 areas to just try and understand how closely the human-animal health will work. There was no environment at that time at all. But then we have moved over some time, and I think this map, we made it last year. I think it might have changed slightly, but we are talking about almost 22 Count One Health units. And what is a Count One Health unit? Is an operational platform that brings together the human or the public health, the veterinary health sector, and also the environment. Some counties incorporating disease risk, some weather, the meteorological aspects of what. But for the counties to operationalize the Count One Health units, there's a need actually for them to work hand in hand. In Kenya, we have at the national level, now under the KNPHI, we have the Public Health Emergency Operations Center, which we call the FIO. But some counties, about actually maybe the latest that we had checked, I think it was about maybe half of the country, they have fully operational what we call the EOCs. So the county EOCs, the momentum is actually for them to integrate One Health issues into them. But we have also issues to do with the antimicrobial resistance. So when you see the CASICs, which is the County Antimicrobial Interagency Steering Committees, they work hand in hand at the lowest level. We have about 20 across the country. They also have the food safety committees that are very close actually to realizing the potential of the whole country fully being operationalized. There are a number of counties that have moved to develop strategic plans, and we are very happy actually to have supported some of these counties. And I'll just use an example of Kajiado, which I think a few months ago was able to launch this. Turkana and others have done it under the guidance of the ZDU and other partners. So this is how One Health can be realized at the lowest level as a country, and helps us actually to improve our preparation, our preparedness aspects. Our milestones have been very phenomenal, in my own opinion, that it's not just a concept, but there has been tremendous action whereby in the last, I would say, actively maybe 13 or so years, I think we have seen this huge transition of One Health, and our ability to operationalize it seamlessly stems back way in 1993. I think at that time, because we have had rabies in this country documented for some of the work that we've published actually for more than a century. But in 1993 is when the first time, at that time, groups from the TDR, the WHO initiatives and others worked with the government to come up with a rabies working group. There has been a transition over the years, and quickly we leap forward to 2012 when the ZDU was established on a memorandum, but also there was an attempt actually to develop a strategic plan. At that time, the strategic plan was more of human and an animal. But as we moved to 2021 quickly, and most of you who've been around, I think we were able to develop 3, I normally call it a trifecta of One Health. So we had the One Health strategic plan revised, we had the anthrax guidelines, and then we had the brucellosis guidelines. And this momentum has continued because Kenya, marching towards eliminating dog-mediated human rabies in 2014, again launched the elimination pathway, the stage-wise elimination pathway being supported by UWA and many other agencies. But now coming closer home, I think the realization of many of these, what we'll call epidemics, but have potential to become pandemics. We developed actually also last year a very good document for Marburg virus, and we're actually really focusing on the One Health aspects just to contain these spillover interfaces. From Marburg, I think we have thought that instead of developing one for Marburg, one for Ebola, and one for other viral hemorrhagic fevers, we try actually to just have one which we call for a filovirus. But Rift Valley fever has been one of my favorite. By favorite, I would say that it's been an interesting disease. So way back, I think in 2014, we began a journey of revising a national contingence plan. And I'm very happy that 2 days ago, actually, Mutiria, Adija, and team were able to deliver on this. So whereby we have a new national contingence plan, 2025, that has 13 standard operating procedures ranging from case management to surveillance, and also just to probably provision of medical countermeasures and so on and so forth. But one of the biggest things that we have also delivered on this is what we call the decision-making tool for public health emergencies. We abbreviate it as the DMT. 2 weeks ago, actually, we validated the first ever DMT. Actually, at a country level, we would say is the first in the world. So Kenya is taking this initiative. Actually, I will talk about the DMT later, but is a tool that helps you to make a decision. And we have what we call trigger cards, and many of the diseases that are also there are zoonotic diseases. So as we progress, I think we have to be very proud as a country to have made milestones over many years, but more significantly, actually, in the last decade, I think Kenya has been at a world class to showcase what has been done. And some of these, I've already mentioned them. I think the 2030 is just around the corner. I don't know how far we are with our efforts actually to eliminate rabies. And I think I talked about the brucellosis, which is expiring this year. And I think there's efforts by the ZDU to start working on this, to have another plan. And these plans are not supposed just to be kept on shelves. They're supposed actually to be utilized specific areas, whereby we focus on research to provide evidence, but also we focus actually in the role that communities play. I've talked about anthrax, I've talked about the Marburg, and also I've talked about this very beautiful document that has been developed. And many thanks actually to the ZDU for taking lead in this. And not forgetting that AMR also is a very big issue, and there's a very big continuum of documents that actually govern AMR. Just apart from this, I think there are issues of actually, pharmacovigilance that are being looked at the interface of imprudent use of antibiotics in animals. How does a Maasai or probably somebody in Northeastern use antibiotics actually to treat their own animals, and they get actually in the food chain? And these are the aspects that actually are being looked at. So Kenya has been able actually to do that. But back in 2020, with support from the USAID, we wanted to map out One Health activities. And by mapping up One Health activities on extensive engagement, all the way from academia, research, industry, and also the counties. And we were actually impressed that most of the activities, when you look at the intensity of the map, most of the activities are actually where there's the intensification of livestock. That's where most zoonosis occur, and that's where most of some of these One Health interventions are actually done. But closer home, we are seeing urbanization driving this picture, whereby closer you move to urban areas where there are a lot of people and borders, you realize that our map starts to darken. Now, the areas that have the lighter shade does not mean that they do not have the burden of these zoonotic diseases. It just means that maybe the data is not very good enough to inform decision making. And the intervention areas, interestingly, weighing from surveillance to research, I think the institutional policy and legislative frameworks came up as an area that needed much attention. And we don't have a One Health policy. If you don't have a One Health policy in a country, it doesn't give you the legislative momentum to make some decisions. It's a political drive, but also it requires actually an act of parliament, and it takes some time. These are the areas that actually we are investing in, and not actually forgetting about the role what biosafety and biosecurity plays. You have actually to invest also in the medical countermeasures, vaccines. Kenya is now actually established the BioVax, and we also have Kevevapi for the animal vaccines. So I think with the challenges that are being faced in the global health landscape, I think we can still showcase that 5 years ago, if today we did this same work, I think probably we'll realize that our map probably is clearing a bit, or maybe is intensifying in some of these areas. But also, for us to realize this very strong marriage between human health and animal health, we have what we call the International Health Regulations 2005. This is legal binding agreements between WHO member states, but also we have what we call the Performance of Veterinary Services, what we call the PVS, and this is from the UA side. Now, for countries to try and synergize and understand how we work better, in 2021, we actually conducted what we call the bridging workshop, which we normally call the NBW. I've been fortunate enough to be Kenya's NBW for the last 5 years, and what we've seen over some time is that there is a need actually for us, as we develop this roadmap, to focus on joint risk communication, joint risk analysis. I'll explore some of these areas in a nutshell, whereby you develop frameworks that can help you actually not to go separately to investigate a disease, but you go as a team of animal health experts, veterinarians, epidemiologists, and public health guys actually to go as a community disease reporters, or probably sometimes what we call the CHPs currently. And we have moved with this momentum, what we'll actually show, just apart from doing it at the national level, to the sub-national level, to do what we call operationalizing the joint risk assessment. So as you can see on the right side, actually we have what we call the MCM. So MCM is a multi-sectoral coordination mechanism. Again, also the auspices of WHO, UA, and many other agencies. And again, in 2012, I think we were among the first countries, and actually the publication by the Tripartite actually uses Kenya as a case study of the MCM. And the MCM coordination plan actually just outlines how countries are supposed actually to be working closely, but also at the lowest level. So you might be wondering, what is joint risk assessment in a nutshell, and I'll not dive so much into it. Joint risk assessment actually, helps you to assess the potential risk of introduction of a pathogen of zoonotic nature by using mechanisms that have been established between the animal health sector and the human health sector. And this framework that we have developed and actually be able to roll it out at the sub-national level since 2019, when we did actually the piloting in some countries. But I think this momentum has moved until 2022, when we had the first JRA, and I think this was a very big, I think we did like 8 diseases, but basically, without looking at many of those diagrams, the potential for the highly pathogenic avian influenza was in Bungoma because of the border with Elgon side, and this has been documented in other countries. And of course, the Ebola, the ever risk of Ebola being introduced in Kenya was also examined from the Busia border, and we have the recurrent outbreaks of anthrax in Kakamega County, while rabies is actually widespread. And so when do you activate the JRA? You only activate the JRA actually when there's evidence that the disease actually has jumped from animals to humans. And so there's momentum actually to institutionalize JRA to be a standard in most of the risk assessment mechanisms that we put together. We have a lot of sector-specific risk assessments. We have the animal health sector, the environmental sector, and the public health sector. For example, in Kenya, we developed the STAR as a document actually that guides our risk assessment. But then we are collapsing all these things and saying that we need a joint risk assessment. And this helps us to save time, so that when you have those heat maps, you only focus on the areas that are red, and these are the areas that actually give you, they save time and they save resources for you as a person to go in there and actually start implementing interventions at that interface. Now, one of the key things, and how do we operationalize One Health, I think I'll just pick 2 examples. I'll pick one example in terms of integrated surveillance, which we have done quite well, but also mainstreaming workforce systems. And these capacity building aspects have been done very well. And I'll not really jump into so much of this, but when you look at how preparedness is done, we are looking at an aspect of actually embedding what we call the CABS. CABS is an animal health surveillance system. that is domiciled by the DVS, supported by WSU and other aspects. But also we have the MDARURA, what we call the event-based surveillance system. For many of you, during COVID-19, probably you heard about MDARURA, and I think this was actually limited at that time just for the port of entry at the airports for travelers who are coming in the country, but also it was piloted in about 7 counties, but now it has been rolled out. And in terms of how to institutionalize this, we have what we call the IDSR. So the IDSR is a WHO Afro agenda for all WHO member states, about 50-something, that actually outlines how surveillance and reporting has been done. And in every country in Kenya, we have 46 IDSR priority diseases. Among the 46 IDSR priority diseases, I think about 10 or 12 are actually zoonotic diseases. And one disease that comes out actually every time we speak about this is a disease like anthrax, brucellosis, Rift Valley fever, and so forth. I've already talked about institutionalizing MCMs. I will not repeat, about COHUs and actually NASICs and how we've moved actually to build systems by putting together what we call the FEM framework of training animal health, public health experts together so that they could actually have the same level of capacities in responding to outbreaks of some of these diseases. There's a continuum of many of these IHR mandatory activity. The only mandatory activity in the IHR is what we call the state party annual reporting mechanism. And the SPIRE is done every year, coordinated by the WHO, and it scores countries on 15 core capacities and 35 indicators. And among most of these, actually, there is an aspect of zoonotic diseases and One Health capacities that actually help the countries actually to evaluate themselves how they can do better. The rest of these other activities that you see here under the IHR monitoring and evaluation framework, they're voluntary activities. It means that countries will decide to do them, or countries might not decide to do them. But one of the things that we've done as a country, that back in 2016, when Kenya did its first what we call the JEE, I think in 2024, I think we did another JEE. And then we'll continue actually implementing issues to do the 717 and so on and so forth. So I'm being reminded my time is almost up, so I'll try to move a bit faster. We'll share these slides with you for you all. So moving away from this, Kenya, like many countries, has been contributing to the pandemic treaty. And probably most of you are asking, what is a pandemic treaty? This is just, it used to be called a pandemic agreement, but there was a volatile disagreements and it became a pandemic treaty. So as I said, again, is a legally binding document that member states actually contribute. And Kenya has been tasked actually specifically to look at Article 12, which actually defines what we call FIC. And the KNPHI and others have been actually looking at some of these issues. I'll not really go into all the aspects, but I'll just highlight the issues to do with the One Health and how the country has been able to do this. So Article 12 talks about FICs, and FICs is just looking at who declares an emergency and when an emergency is globally is declared to end. So our strategic areas is actually to build an IHR authority, not an IHR focal person. Now we have an IHR authority, but also digitization and the issues to do with One Health. And I talked about biovacs and the long-term aspects of actually mobilizing resources. This brings us to a key theme, and I've already talked about what a FIC is an extraordinary event that has public health implications. It's sudden, it is unprecedented, and sometimes it can affect international trade. So when you have a FIC, and some of the examples that we've had, 15 FICs probably over the few years, Mpox right now has been declared a FIC twice. Actually, it's the only that has been declared a FIC twice, but then it was downscaled. We are focusing on equity as a country to access some of these products, sharing pathogens, developing vaccines, financing aspects, and actually using the One Health issues to strengthen our preparedness. And this brings me to the Pandemic Fund. The Pandemic Fund is an initiative of the World Health Organization, but with funding specifically from the World Bank. Kenya, like many countries, have been actually trying to get this funding, and I think you see those 3 areas where the Pandemic Fund talks about surveillance systems, early warning, the lab aspects, but also it talks about capacity building. And so we have put in an application again for the 3rd time for $25 million US. We are crossing our fingers. I think this time we're going to get it by the 19th of this month. We'll know if Kenya will get the money. But also we have been working as an initiative to apply for an extra $40 million as a regional entity proposal, but also as a multi-country proposal. So if these resources actually flow into our systems, we'll be able actually to focus on key issues. Building our workforce by actually using FELTEC, for example, or ISAVET, but also digitizing our aspects. For example, when you build virtual platforms, to embed into what we call the global health emergence scopes. So when you go online, you'll see what the global emergence scopes is. So we want to use the pandemic fund resources actually to strengthen this to the sub-national level and actually move into most of those things that I've already talked about, the 717 and others. In this area, I think we are very proud actually to be the first country, as I said, to move just from action, to move from just alerts, but we are now trying to operationalize this decision-making tool based on the Annex 2 of the IHR of the WHO. This tool is going to be rolled out very soon to help surveillance officers, veterinarians, and others who are working at the lowest level actually to make decisions. So we have moved actually to develop a pocket book, and this pocket book actually has 20 trigger cards for all these diseases, including the zoonotic diseases, which are 5 in this aspect. So then the next aspect is collaboration with WSU, Palladium, and others, is actually to digitize this and then share with it at the sub-national level as an AI chatbot, probably, where you can query it and it gives you the clusters, but also most importantly, being very, very innovative that it avoids waste of resources or also ad hoc response mechanisms. I'll rush through Rift Valley fever. I think most of you know the outbreaks in Wajir and Marsabit. The work done by FLTP is incredible work, and this is a One Health momentum actually for the country, where they've been able to sample humans alongside animals and also vectors. And for vectors like mosquitoes, they have even gone ahead and actually tried to differentiate in terms of diagnosing acute febrile illnesses. But back in 2017, yes, I'm almost finishing. Back in 2017, we developed the first Rift Valley fever policy brief from the TDR World WHO funding, and this has actually been revised over time to, to help us do this. So as we move towards this, I think there has been all these issues that we've discussed about, and I think conducting of intra-action reviews for anthrax, for brucellosis, and also for mpox, I think as a country we've done also very well to meet our obligations that report to WHO. And as I almost come to the conclusion, of course, there have also been some challenges. And some of these challenges actually, that while there is a progress is undeniable, our systems remain siloed. There is actually issues to fragmentation of our resources. And also we're having issues to do with actually the workforce capacity, the attrition rates, and then actually weak surveillance systems. But we have an opportunity actually to use at the community level to now deploy AI in terms of epidemic forecasting and actually be able to bring in aspects of digital transformation, but also harness the systems that exist actually to build capacity as the zoonotic spillover. And then that is the DMT. I'll not talk about it much. This slide, I'll not look at it, but we have challenges in funding. I think this is the same mapping that we did. I think when we do it right now, everything here will change. You know why? Because there's no USAID anymore. USAID collapsed. So 2020, you see USAID and CDC were our greatest funders. So this graph will totally collapse, and maybe we might just remain with a few other areas. So finally, our call to action is that we have actually to move from the silos to synergy. And as we commemorate this World Health Day, let's remember that One Health is a shared duty that needs us to unite, integrate what we do, invest more in our resources, but more importantly, invest in our communities. And I'll end this by actually highlighting these two documents, because these are the new babies on the block. Having this contingence plan that has taken over a decade, but also having these testing guidelines in humans that has been done to help us actually by protecting one, we'll be able actually to protect all. And remember that pandemic preparedness does not begin in boardrooms. It doesn't begin on when you go for the outbreak, but it begins much earlier when you're doing this preparedness. So I think as a country, we've done very well. And I'll finalize this, that as the Center for Global Health and Pandemic Intelligence, I think we are at the forefront of supporting the government of Kenya, working closely with the ZDU and the KNPHI. And we call upon you to support us in driving this agenda for the various technical areas that we have provided. Thank you very much for giving me this opportunity actually to highlight some of the things that we've done as a country.